Welcome to the inaugural session of the Gulf Amyloidosis Club. My name is Firas Al-Badareen, and I am the head of the imaging working group of Emirates Cardiac Society, and I'm also a cardiologist at Cleveland Clinic, Abu Dhabi. Tonight, we're going to launch the exciting project. As I said, it's called Gulf Amyloidosis Club, with a very simple but powerful objective: to raise awareness and bridge the gap between knowledge and action. Our mission is to raise awareness about cardiac amyloidosis and go through, in a systematic way, a series of sessions to educate colleagues, friends, and healthcare providers about the diagnosis and treatment of cardiac amyloidosis. Before we start and I launch the first session and introduce the speakers, I would like to acknowledge a couple of things. First, this inaugural session coincides with the World Amyloidosis Day, a day dedicated and devoted to shining light on cardiac amyloidosis, this condition that it is very frequently underdiagnosed and underrecognized. So today is the day to raise awareness, spread the word, wear something orange in this occasion in recognition of this disease. I also would like to acknowledge our sponsors whose generous support made this effort possible and feasible. And with that, we'll get right to it. And I will launch the first session with the focus of screening patients for possible cardiac amyloidosis. And we have a couple of esteemed speakers. We'll start with Dr. Saurabh Malhotra, who's a very close friend and colleague of mine. We met, I don't know, many years ago, Saurabh. We were doing imaging training, and now here we are talking about cardiac amyloidosis. Saurabh has had an illustrious career path. He currently leads the amyloidosis program at Cook County Hospital. He's a professor of medicine, and he's a man of multiple talents. Tonight, he's going to talk to us about screening for cardiac amyloidosis, and he will share with us his experience in the south side of Chicago. Saurabh, take it away.
Thank you, Firas, and good evening to everybody. It's a pleasure to be here, and thank you for the opportunity to present and share my experiences. I do want to highlight that amyloid screening for amyloid and testing for it has to be developed locally. So as you will see in my and appreciate in my talk. We empowered ourselves to develop a model that we wanted to use in our health system. I know Dr. Ramsey is going to talk about something that he is working on as well, but the screening has to be determined by your infrastructure at your institution, what you have at your disposal, and not to try and emulate what others have done. And it has given me great joy that we've been able to build this ground up with the help of our trainees, colleagues, imaging staff, and other members of the hospital. And it needs collective effort from all of them, but of course, it does need a few champions, which I hope you all will become in the future. These are my disclosures. So just quick recap on pathogenesis of ATTR cardiac amyloidosis. As you can see, this is a beautiful diagram from a publication showing the pathogenesis. Amyloidosis is TTR amyloidosis is generated from a protein, TTR protein, that is produced in the liver. I just want to make sure, Firas, you're seeing my screen correctly here.
We see your slide, but it is in presenter mode.
How is this now? Can you see it, the full screen now?
Not
okay, let me try and share this again. I just want to make sure I can. Oh, here. do that. Screen 3, my bad. Okay, how's that?
It's
Can you see
thinking.
my Can you see my
Perfect.
slide?
Good now. Good now.
Yes. Okay. Thank you. So, so TTR or transthyretin protein, TTR stands for transporter of thyroxine and retinol, is produced by the liver. It has a tetrameric form, which is normal. This dissociates into its individual monomers. You don't have to remember these pathways. There's a dissociation pathway, there's a cleavage pathway, but the end result is that these individual monomers are unstable. These coalesce together to form amyloid fibrils, which are insoluble, deposit in the heart, resulting in increased thickness of the left ventricular wall, arrhythmias, and restrictive cardiomyopathy. These amyloid fibrils are resistant to proteolysis, and again results in ongoing deposition. And initially, the disease may start as an indolent disease, and then over time it becomes progressive. There are two main forms of ATTR cardiac amyloidosis. One is called the wild type form of amyloidosis. This is prevalent worldwide. We really don't know why folks have this form of amyloidosis. We think it is related to aging population. However, we have a patient, and I've heard from others who have patients in their late 50s. Others have also acknowledged presence of wild type amyloid in family members as well. So it's still unknown why people develop wild type amyloid, but it is the more prevalent form of ATTR amyloid, and its prevalence is worldwide. The other form of amyloid, ATTR amyloid, is the hereditary amyloid, and the three more common mutations resulting in hereditary amyloid are listed here. The V122I or the V142I mutation, which is what we see in inner city Chicago. It is prevalent in about 3.5 to 4% African American folks of African American origin. V30M is the most common mutation worldwide, and again T60A is the Irish mutation. Now, we're not going to focus on the mutations per se. I know when I was asked to give this talk, I was asked on screening on V122I patients, but I wanted to make it a bigger, make the objective a little bigger and not just focus on the V122I patients, which is essentially what we see. And those patients are very different from patients and folks in the Gulf. So we want to broaden our horizons and apply our knowledge collectively to try and identify patients across different ethnicities. So wild type amyloid historically has been reported in elderly men. There is a significant clinical overlap in the wild type and hereditary ATTR amyloid patients. So just by age or by ethnicity, you really cannot differentiate wild type from hereditary ATTR cardiac amyloid. And that is why the knowledge of the population mix is very, very important. And that is why when you develop mechanisms for screening of amyloid patients for amyloidosis, you have to develop your own screening methodologies, because there may be clinical peculiarities that may be prevalent in regions where you practice, which may be very dissimilar to what I see in my patients. I'm going to stress upon this on multiple occasions in this talk. The knowledge of mutations, if you have patients with hereditary amyloid in your regions, is very, very important. Not only because it helps determine the risk in the families in the future, but also that the mutations determine the clinical penetrance or the presence of or development or timing of the development of the phenotype, as you can see here. Wild type ATTR typically occurs or presents later in life, as opposed to V122I, hereditary ATTR amyloid, or hereditary amyloid from the T60A mutation. It's important to know, and I hope you all know, that hereditary cardiac amyloid is inherited in an autosomal dominant fashion. So the disease, risk of the disease does not end with the proband or the affected patient. It transmits to the next generation and the next generation and the next generation. So again, important to keep that in mind, that even if you have an elderly patient who you may think is not doing well and you're hesitant from a treatment perspective, you should still complete the workup for ATTR amyloid, which we'll discuss, because if you find a hereditary phenotype in the patient or genotype in the patient, that is very important for the family to know so that their future risk of developing amyloid can also be ascertained. So why do we want to screen for cardiac amyloidosis? The whole dialogue around amyloid, it's a rare disease, or that's what we've been taught or grown up hearing. There wasn't any treatment available for it, so what's the point? And then the prognosis from amyloidosis historically has been poor. So I'm going to show a few slides contradicting this dogma that we were taught when I was growing up and went to medical school, and even very recently before I started and when I started an amyloid program, and that I want you to take this message and use this as an argument against why we should treat for cardiac amyloid. So there's an increasing incidence and prevalence of amyloidosis. This is not just cardiac amyloidosis, but amyloidosis in general. This is data from the US of hospitalizations with diagnosis of amyloidosis in inpatients between 2000 and 2012, and you can see the diagnosis for amyloidosis has been increasing over time. The threshold for a rare disease in the US is about 55 per 100,000. That was met in the year 2012. And is it likely that this is an underestimate because only inpatients, patients who were hospitalized and who were coded in their diagnosis, in the problem list for amyloidosis identified. So we are missing outpatients or patients who will be living with amyloidosis, never admitted to the hospital, or those in whom amyloidosis was never diagnosed or coded in their EMR. Novel therapies are available now, and these target crucial steps in amyloidogenesis. I'm not going to go into details of these therapies. There are therapies that suppress TTR synthesis in the liver, so just kill the TTR protein. These are called as silencers of the TTR protein. The ones that are approved in the US are patisiran, vutrisiran, and eplontersen. These are all TTR silencers. Then we have TTR stabilizers that affect the rate-limiting step, which is the dissociation of the TTR tetramer into its monomers. Two drugs, tafamidis and acoramidis, are now approved. And then we have ongoing clinical trials looking into amyloid depleters or degraders that have that are very promising, and we are looking forward to the results of these clinical trials. So we have 3 drugs that have been approved for ATTR cardiomyopathy: tafamidis, acoramidis, and vutrisiran, that are now available for treatment of these patients. And we know from earlier trials that superior outcomes with early institution of therapy. This is data from ATTRACT trial that studied the use of tafamidis in patients with ATTR cardiomyopathy, showing that the risk of death is much lower in patients who were NYHA class 1 at the time of enrollment in the ATTRACT trial. More importantly, this is data from a very recent publication by Brett Sperry's group in Kansas City, showing that the newer clinical trials wherein the patients we think are historically being diagnosed earlier than what we would have done historically. The survival in the treatment arm of these patients, look at this Kaplan-Meier survival curve from the HELIOS-B trial, which was recently published. This is approaching the age expected mortality of these patients. So with the early detection of this disease, with institution of therapy, targeted therapy early, survival of patients with amyloid is now beginning to approach that of age matched patients without amyloid. So that is very, very important to know. So we definitely have to screen for amyloid. It is not a rare disease. 15% prevalence of amyloid deposits on autopsy studies in patients above 80 years of age. From a personal perspective, the V122I mutation is present in about 3.5 to 4% African-American, Afro-Caribbean patients in Chicagoland and Cook County, where I practice. We have about 1.5 million African-American patients or patients of African-American descent. So if we just did the crude maths, we would have 50,000 patients right now who would be carriers of the V122I mutation. Treatment is available. Both targeted treatment is available. There are 3 different drugs that are now available for ATTR cardiomyopathy, and the diagnosis itself also lends us in doing a better job with non-targeted therapy, better management of heart failure, better use of loop diuretics, and more close monitoring of patients who are receiving otherwise guideline-directed medical therapy for heart failure. The prognosis has improved. It is better with early treatment, and these patients are now beginning to survive similarly to age-matched non-amyloid populations. All right. So whom to screen, and this is very, very important. We cannot go about screening everybody. Of course, let's start with symptomatic patients. So symptomatic patients with heart failure, and I would stress on the fact, heart failure, both HFpEF and HFrEF. A third of our patients with amyloid at Cook County Health are HFrEF at the time of diagnosis. So don't omit patients who have HFrEF. So to avoid this confusion, at least in my institution, when we talk about amyloid, we say heart failure. We don't say HFpEF or HFrEF. Patients with heart blocks, elderly patients have heart blocks. Just because they're old doesn't mean that it's okay for them to have heart block. Amyloid is a disease of the aging population. So if we have patients, elderly patients who are with heart blocks, we have a few in the CCU right now. We are testing for amyloid, and then even young patients with heart blocks. Again, young patients have to have even less of a reason to have heart blocks and need for pacemakers. So definitely test for those patients. Those are easy patients to test for because those are easy diagnoses to find. In asymptomatic patients, it's a little more challenging. You may want to do this in patients with family history of hereditary ATTR, of course. If you know the genotype in the family member, then you can then start screening the family members for that genotype and then test those patients for a presence of subclinical amyloid. And again, patients who may have the hereditary phenotype or the hereditary genotype of the mutation, but they may have non-cardiac symptoms, which occur earlier before and prior to occurrence of cardiac manifestations, which is particularly true in hereditary amyloid patients. So what we use now in our health system here is one second. Let me go back to my screen. Okay, we started a mandate or a process called as Think Amyloid. We developed these educational posters that we put up across different areas in our health system, the clinics, the floors, and we highlighted things that would be peculiar for different, different areas in the hospital. So like if you are in the inpatient service and you see a patient with multiple heart failure admissions or frequent heart failure admissions, then you should think of amyloid. If you have patients with heart failure who are not tolerating heart failure therapy, you should think of amyloid. If the echo report says you have apical sparing strain pattern, you should think of amyloid. So there is a clinical feedback loop with these posters that the primary care physicians and those who are taking care of these patients with heart failure can look at. And also there is a testing-based loop. So if you have a patient who's sent for an MRI scan, a patient who's sent for an echo with strain, the report would then say that we should look for amyloid in these patients. Distribution of cardiac symptoms is very important to keep in mind. And this is again to highlight the fact that the clinical phenotype can vary. This is data from wild type amyloid patients, again, just highlighting the fact that only about 67% of these patients either had heart failure at presentation or had HFpEF at presentation. 60% of them actually did not have low voltage EKG. Most of them actually had normal EKG voltages. You have to keep these things in mind when you are developing your screening algorithms so that you cast a wider net. You use these cues judiciously and don't miss out on the majority of the patients, which would be heart failure, any EF, and those with normal voltages who could have amyloid. If you only look at low voltage patients with HFpEF, that's going to be a very, very small portion of the population. Important to recognize and remember that amyloid patients can have other clinical comorbidities, hypertension, coronary artery disease, diabetes, chronic kidney disease. So just because they have one disease doesn't mean that they cannot have amyloid. So please do not use the presence of these diseases to say, like aortic stenosis. We have aortic stenosis and we have left ventricular hypertrophy. Doesn't mean that that patient cannot have amyloid. Again, aortic stenosis is also a disease of the aging population, amyloidosis is also a disease of the aging population. So just because they have one disease doesn't mean that they cannot have the other. In asymptomatic patients, you have to remember that hereditary amyloid is a heterogeneous disease and the phenotype is determined by the genotype. I do not know what the prevailing genes are in the Gulf area region. You would know that the best. And you really need to use that to your advantage and say, okay, what are the clinical phenotype that correlates with this genotype, and use that to your advantage. This could be carpal tunnel syndrome, lumbar stenosis, neuropathy, GI disturbances, and then overt heart failure, depending upon the kind of genes the patient have or the mutation the patient has. They could have early onset symptoms, which are more neuropathic, or they could have late symptoms, which are more cardiac manifestations. This is one of the algorithms proposed by the SCAN-MP study, which is really screening for ATTR-CM. They are focusing on Black or Caribbean Hispanic individuals with heart failure. They have an age cutoff, they have an echo cutoff, wall thickness, diastolic dysfunction. They're going to use this and use a clinical EHR-based risk assessment. They'll check for TTR levels, they check for biomarkers, then do a PYP scan. If that's positive, then they will do genetic testing to determine wild type or hereditary amyloid. So this is great, but this is again one approach from a study standpoint. What you want to remember, and I want to highlight using observational data from 2 centers here, is that there is a differential distribution of these red flags across populations. So for example, on the left side, this is our Cook County data, very preliminary data, from 6 years ago when I first started here. We found that age by gender, so above 60 years of age, low voltage EKG in the presence of left ventricular hypertrophy, apical sparing strain pattern, which we report on every echo, and chronic troponin elevations were more common features in our patients that we could mine or search in our EMR. And using these, we could find a positive PYP scan in about 87% of our patients. Heart blocks, autonomic neuropathy, and bilateral carpal tunnel were less frequent. And you have to remember that some of these features are studied in wild type populations, and majority, I would not say majority, 50% of our patients are hereditary amyloid African American population who have not been studied very well in the literature. On the flip side, we have a population of 300 white patients, predominantly men, in whom the more common features of pseudoinfarct pattern, low voltage EKGs, lumbar stenosis, AFib, and bilateral carpal tunnel syndrome, which tend to segregate more in a wild type population. So we focus our attention more on the clinical phenotype in patients that we see in our practice. So African American, because they have 4% prevalence of the hereditary, the mutation, the V122I mutation, but can also have wild type amyloid. 50% of our amyloid patients, African American amyloid patients, are wild type, 50% are hereditary. So in our practice, hereditary amyloid is very common. Elderly patients, so we made a cutoff of age over 60 years of age who have increased wall thickness on echo. That is something that is often reported. Anybody can review it and read it and say, okay, there is increased wall thickness. Most clinicians will recognize a low voltage EKG pattern, so that's fairly easy. And then again, red flags that are easy to identify or reported on testing. So low voltage EKG, apical sparing pattern, repeat heart failure admissions, troponin elevation, carpal tunnel syndrome, AFib, gastroparesis, autonomic dysfunction, polyneuropathy. So this is something that our clinicians or my colleagues, either in cardiology or in medicine, would be able to easily recognize and say, okay, there are features in this patient that are concerning for amyloid. The testing, I would say that just like an ischemic cascade in CAD, there's an amyloid cascade. Depending upon where you find the patient, those tests can be specific to sensitive. Systolic dysfunction is very late presentation, so that's going to be, a very late marker. But if you want very specific markers, of course, nucleus integrity with a PYP scan or HTP scan is going to be a very specific test currently available for confirmation of these patients. I would use PYP scan not for screening, but for confirmation. But the screening would involve other tests that come before a PYP scan, which would include echo, left ventricular hypertrophy, as you can see here, strain imaging showing a classic cherry on top apical sparing strain pattern, which actually is stays fairly consistent even in end-stage heart failure patients. So you can see this patient has very low EF, very bad strain, but again, the apical strain is better than the basal mid strain. But this doesn't work all the time, so you have to be cautious that patients who have hypertensive heart disease, chronic kidney disease, the apical sparing or the cherry on top pattern can be falsely abnormal because of them having chronic kidney disease. And you just have to be careful when you report this or use this technique from a screening standpoint. But I think that if you have patients with left ventricular hypertrophy and they have a cherry on top pattern, those patients should absolutely be screened in the right clinical context for TTR amyloid. The next is MRI. MRI is a class 1 indication for the ESC guidelines in patients who have unknown heart failure, HFrEF, even HFpEF. It has a very good sensitivity specificity for amyloid. And you can see two different patients here with a diffuse late gadolinium enhancement, increased T1 times and extracellular volume. And then you can also have abnormal gadolinium kinetics that can increase your suspicion for amyloid in these patients. MRI is a great tool. And when you have done a clinical screening and a preliminary imaging-based screening with echo and MRI, then you can go on to doing confirmatory testing with a combination of genetic evaluation and also PYP scans. The MRI is important to highlight, does not differentiate between ATTR and AL amyloid. That's why I say I think it is a great screening test for ATTR amyloid, but it's a great diagnostic test for amyloidosis in general. Who should initiate the screening? This is very, very important. Should it be the cardiologist? Should it be the neurologist? Should it be somebody else? And this is important to remember that non-cardiac symptoms precede cardiac manifestations in amyloid. And this is an example of one of our patients. He was 74-year-old gentleman, African-American gentleman, atrial fibrillation, heart failure. He has a prior history of bilateral carpal tunnel release several years ago, has been suffering with continued polyneuropathy. This patient was being seen by his primary care physician for several years, over a decade. So it's not just a cardiologist's responsibility to screen for these patients, but our responsibility as champions of ATTR cardiac amyloid to partner with other colleagues. And we partner with primary care physicians and neurologists at Cook County Health to help us initiate screening early. So when I say initiate screening, I say I request them to inform us if they suspect a patient that may have amyloid or features of cardiac amyloid or features of systemic amyloid. Amyloidosis is a systemic disease. And then we can then initiate the process of the testing that is required to confirm a diagnosis of amyloid. So you can take help from your colleagues, not to overburden them, but tell them, hey, raise the flag, let me know who you suspect amyloid in, and I will take the ownership of diagnosing these patients. Very, very important that non-sequential genetic testing must be performed in all patients. And this is true for endemic populations where the mutations are highly prevalent, such as ours. So let's say, take some examples. If you just did a PYP scan or HTP scan and genetic testing, you would miss out on identification of a multiple myeloma in this patient. This is a patient whose PYP scan is negative and is mutation negative. On the flip side, you have a patient who is mutation negative but has MGUS, and this patient would have been labeled as possibly as multiple myeloma, but the PYP scan was abnormal and diagnosed this patient has ATTR cardiac amyloid along with MGUS or a smoldering myeloma. And the last but not the least, you have a patient who has a negative assessment for light chain disease. You have a negative PYP scan, but this patient had an abnormal genotype. So you would miss this patient from an early diagnosis and screening perspective if you did not test for the patient's mutation. This patient was ultimately diagnosed with amyloid polyneuropathy and was treated with silencer therapy because of the genotype for TTR amyloid and also with polyneuropathy in this patient. Why is the knowledge of genetics very, very important? Genetic screening is very important to identify high-risk populations. This is data from the ARIC study showing African Americans who are just carriers of the V122I mutation have a higher risk of, a greater risk of, or a lower freedom from heart failure admissions as opposed to non-carrier African American patients. So this is very, very important, and not only from a familial perspective to understand the genetic risk in the population, but also because they have a clinical risk as well. So genetic screening identifies preclinical ATTR. This is clinical cardiac amyloid, which could be ATTR or light chain disease. This is subclinical cardiac amyloid in a patient who has no heart failure, but early signal for amyloid in the heart. And then you can have a preclinical cardiac amyloid. That is those who are at risk. They may not have heart failure, but they may have non-cardiac manifestations. And these patients can have mutations for TTR amyloid. And again, in a high-risk population in whom the genetic, the genotype, pathogenic genotype has been identified, genetic risk should be done early on and not at the end, at least in my opinion, and that's how we practice here in Cook County. What does genetic screening allow? It may allow you for amyloid prevention. And this is not futuristic. This is happening right now. We are part of a prevention trial called ACT Early. We identify patients based on the genetic risk and randomize them to receiving acoramidis or placebo with the endpoint of development of imaging evidence of amyloid in the future. So again, genetic risk is very, very important. So screening for cardiac amyloidosis, identify population at risk, raise a clinical suspicion, perform screening tests to strengthen suspicion. So think amyloid. These are the things that go into thinking amyloid. If you don't think amyloid, you will never diagnose amyloid. And then the next step is refer for confirmatory testing to your specialists, to your colleagues who are championing the amyloid in your institution, and then refer them to a specialist for treatment. And this is a refer directly approach, again, two-step approach that we have employed at Cook County. And with that, I will stop. Thank you so much for your attention.
Thank you so much, Saurabh. That was absolutely fantastic. And I will build up on your mantra. I would say, think amyloid. And in the occasion of World Amyloidosis Day, let's talk amyloid. And once we diagnose patients, let's treat amyloid. So let's do all of it together. So I'll move to the next speaker, who's also another close friend of mine, Dr. Ramzi Tabbarat, who is the director of the Abdali Amyloidosis Center in Amman, Jordan, who will talk to us about specific area within screening, the use of EMR-based tools. And let's see what Ramzi has to tell us. Ramzi, the floor is yours.
Thank you for giving me the opportunity to participate in this program. I'm going to try to share my screen. Yeah. Let me know if you can see my screen.
You're good.
Okay. So we're going to focus on how to screen for cardiac amyloidosis because I think this is a very important topic. What I'm going to do is I'm going to discuss how EMR can be used to increase the opportunity of finding patients who may have ATTR amyloidosis. And the information in my presentation comes from a study published in May of 2024 with the title Using Electronic Medical Records to Identify Patients at Risk for Underlying Cardiac Amyloidosis. And I have to remind you that the source of the data comes from the USA. And this is only just to emphasize what Saurabh just said, that we can look at these data with interest, but they don't necessarily apply to our population. So if we need to do proper screening for our populations here in the Middle East and in the Gulf area, we have to look at the phenotype of our patients because they can be different from how patients in the USA or in Europe present, and then maybe design a screening program based on the findings in our patients. So I don't have to remind you, this has been said before. The major problem with amyloidosis these days is not really making the diagnosis in a specialized center. It's the time that a patient takes before they get to a physician who understands amyloidosis, who can make the diagnosis of this disease in a timely manner. And typically, a patient loses about, on average, about 3 years, sometimes even 4 years, before seeing multiple physicians from multiple specialties before they eventually get the correct diagnosis. And this slide here shows you the delay in diagnosis from various parts of the world. Some of these studies come from North America, from Europe, and even from Japan. And they all show you that on average, the patient waits about 3 to 4 years before they get diagnosed. And really, only about 35% of patients with the hereditary type of ATTR amyloidosis are diagnosed within 6 months of the initial presentation. Only 46% of those with ATTR wild type are diagnosed within the first 6 months of the presentation of their disease. So you can imagine the suffering of these patients running around trying to get a diagnosis or trying to find an explanation for the often severe symptoms that they have. This is important because now we're trying. I mean, if you want to help a patient with a chronic disease, the earlier you diagnose that disease, the better the prognosis will be. And this can be seen clearly on this slide. So this is on the left side of the slide, you can see patients with the wild type ATTR amyloidosis. And these patients can be staged from stage 1 to stage 2 to stage 3, depending on some markers. And you can see that the survival probability depends on which stage you're diagnosed in. So if you're a patient with stage 3, the probability that you will be alive after 5 years or after 60 months from diagnosis is down to 25%. However, if you are a patient with stage 1, then the likelihood that you will be alive 5 years down the line would be about 75%. And the only reason for why patients would be diagnosed with stage 3 is because they waste time and from the time they get their symptoms until they're diagnosed. So if you catch these patients early, you are likely to diagnose a lot of these patients when they are in stage 1, which will have a great impact on their survival down the line. And the same thing is also true for patients with the hereditary type of ATTR amyloidosis. Now, the problem is why these patients spend a lot of time before they get diagnosed, because this is a systemic disease that involves different organs in the body that is really confusing to physicians. So the gastrointestinal tract can be involved because of autonomic dysfunction, presenting with symptoms of chronic diarrhea, constipation, significant weight loss in these patients, early satiety, and intolerance to blood pressure medications with orthostatic hypotension. Very commonly, they may have unilateral or bilateral carpal tunnel syndromes. Problems with the joints and bones can present with back pain, lumbar spinal stenosis. Peripheral sensory motor neuropathy is a very important and debilitating manifestation of the hereditary type of ATTR amyloidosis. Cardiac, of course, the most commonly involved organ. Patients will present with heart failure. They can present with atrial fibrillation, conduction abnormalities, and eventually, probably they will die from their cardiac disease if not treated. They can have problem with their joints in the shoulders, knees, hip pains that may require repeated surgeries. Ruptured biceps tendon, the so-called the Popeye sign, is not a common, but it's a feature of ATTR amyloidosis that we should look for. And trigger fingers is also another feature. Autonomic neuropathy, in addition to the peripheral sensory motor neuropathy, can present with orthostatic hypotension, urinary incontinence, and erectile dysfunction. So you can imagine why a lot of these patients go undiagnosed, because it depends on where they think their worst symptoms are. If their worst symptoms are related to the gastrointestinal tract, they will go to seek advice from a gastroenterologist. If it's a problem with the peripheral nervous systems, they will go to a neurologist and so on and so forth. The neurologist cannot diagnose the disease, then they have to switch to another physician and so on and so forth. So that causes a lot of wasted time. So the current study, the one that we will discuss, is really trying to see if we can use data that is already present in the electronic medical records of patients in hospitals. And if we take a look another look at these data and maybe pick up some of the red flags, some of the diagnoses embedded in the electronic medical records of some of these patients. Maybe we can find patients who have a higher likelihood of having ATTR amyloidosis, and then maybe we can further screen these patients in order to make a diagnosis. So what they were trying to do is they were trying to develop a scoring system from the EMR system using the ICD-10 codes and also the CPT codes, which list the diagnoses that the patient present with, and then build a scoring system for these patients. So in order to be, selective, they picked patients who were older than the age of 60 because, this is the age where amyloidosis is more prevalent. And those patients had a diagnosis of chronic diastolic heart failure. And I think they wanted to do this is because this, looking at these patients with HFpEF will make it more likely to find patients with cardiac amyloidosis. And of course, all of these patients should not have had a previous history of amyloidosis. And then they built a risk score based on the ICD-10 and CPT codes, as I will show you. So they picked these diagnoses from the EMR, from the ICD-10, and they gave each one a score. So if the patient had a diagnosis of carpal tunnel syndrome, this was given a score of 5. And we can talk about why they picked these signs and symptoms and why they gave them these different scores, but this is, I don't think we have time to discuss this. Patients with aortic stenosis also were given a score of 5. Those who had conduction abnormalities, a score of 4. Diagnosis of atrial fibrillation was given also a score of 4. The presence of neuropathy for right ventricular failure or pulmonary hypertension, a score of 4. The diagnosis of a bundle branch block 3, hepatomegaly 2, non-traumatic bicep rupture 2, ascites 2, chronic passive congestion of the liver 2, and a 6-sinus syndrome in the diagnosis was given a score of 2. So the total score from the ICD-10 was 39. And they also added diagnoses from the CPT codes, which included history of TAVR or SAVR, given 5, a score of 5. This is because of the well-known association, as Suraf said, between aortic stenosis and ATTR amyloidosis. Patients who undergone magnetic resonance imaging with findings were given a score of 4. Placement of a pacemaker 3, hip arthroplasty 2, knee arthroplasty also a score of 2 with a total of 16. And also they looked at some of the lab results of these patients and they gave a elevated NT-proBNP levels a score of 4 and elevated troponin levels a score of 3 for a total of 7 scores. And then based on these 3 different scoring algorithms, they decided that those who had a score of 30, collectively a score of 30 or more, were termed as high for the probability of having amyloidosis. Those who had a score of less than 10 were discarded because the score was low, and these patients did not have a consistent availability of echo data. And those between 10 and 19 were termed low to intermediate. Okay, so you've noticed that there was a gap between 30 and 20. These patients were not included in the analysis because they just wanted to separate these 2 groups and not have data that is, closer to the high group or closer to the non-significant group. So they picked 10 to 19 as a low to intermediate score. So what they did, they found 132 patients who had a score of 30 or more, and these were enrolled as cases or high likelihood for amyloidosis. And they also picked 132 patients who had a score of 10 to 19, and they all had adequate echo data. Remember, what they're trying to do is trying to find these patients, the high score patients, in order to do echocardiograms on these patients, because the initial informative test when you're looking for patients with amyloidosis is an echocardiogram. So they wanted to know out of which of these patients is likely is an echocardiogram going to be informative to rule in or rule out cardiac amyloidosis. So again, we have 132 patients in the high risk or high score group and 132 patients in the low to intermediate risk group. And if we look at the clinical characteristics of these two groups, the high risk with a score of 30 or more versus those with a score of 10 to 19, we can see that there were more males in the high risk. Of course, there are more males in amyloidosis in general. And the age of the both groups were similar, but if you look at all the others, there were more African Americans in the high risk group. Increased LV wall thickness, or the LV wall thickness was significantly more in the high risk group. The LV in diastolic volume was also more in the high risk group. The LV mass index gain was also more in the high risk group. The mitral valve E to A ratio, a measure of diastolic dysfunction, was also more prevalent in the high risk group. LAVI, or left atrial volume index, which gives you information about the size of the left atrium, was more in those patients with the high score. The LV ejection fraction was lower in the high score group, and the myocardial contraction fraction was also lower. And TAPSE, which measures the function of the right ventricle, was lower, indicating more right ventricular dysfunction in those with the high risk group compared to the low risk group. So these are two distinctive groups in terms of maybe clinical presentations and also in their echo findings. Based on that, they also designed a score group or scoring system depending on some echo findings, and they just wanted to find if there was a concordance between the high risk category group and the echo findings that are also very common in patients with cardiac amyloidosis. So they give a left ventricular mass index over 100 gram per meter square, score of 1, LAVI, left atrial volume index more than 34, score of 1, myocardial contraction fraction less than 40, a score of 1, mitral E to A ratio more than 2, a 1, and mitral E to E prime more than 10, a score of 1. And also they included some demographic findings. So if you're African American, then you also get a point, and if you're a male gender, you also get a point. So this is how they did it. So what did they find? Well, first of all, when they looked at the TET, the transthoracic score of more than 4, indicating that there are more findings on the echocardiogram that are indicative of cardiac amyloidosis. 43% of patients with the high score had a score of 4 or more, by only 11% of patients with the low score, low to intermediate or 10 to 19 score, had a score, a transthoracic echo score of 4 or more. And the difference was clinically significant. So what they concluded from this trial is that the EMR, the electronic medical records, can be used to flag high-risk patients, those with a score of more than 30, through best practice advisor alert. And the proposed scoring system was also congruent with the expected echocardiography data in cardiac amyloidosis. And this scoring system can encourage screening during echocardiography. So when you pick these patients from the electronic medical records, those with a high score or score more than 30, then you can refer these patients to an echocardiogram looking for the presence of signs of cardiac amyloidosis. And that would be the gateway to early diagnosis or early identification of these patients. So when I read this paper, it was, I thought it was very interesting. I had few comments related to this paper that I would like to share with you. I totally agree with the conclusion of the researchers that using electronic medical records can help better identify patients with cardiac amyloidosis and maybe lead to earlier diagnosis and earlier prognosis. However, EMR and ICD-10 codes and CPT codes are not available everywhere. And I'm not talking about maybe other countries in the region, but I'm talking about my country, Jordan, where we have very few hospitals in Jordan that have EMR systems. And even when we have EMR systems, fewer hospitals use the ICD-10 and CPT codes in our system. So one of the drawbacks of such a scoring system for it to be implemented in our region is probably the inavailability across the board or across the countries in the region of an electronic medical record system, and also the not uniform applicability or application of the ICD-10 and CPT codes in these hospitals. Another point, and I think it's a very important, is that this study was done on a USA population. Now, whether the USA population differs from the population in the Middle East, we really need to know, because that's very important. And Suraf alluded to this, is that we should look at data coming from other countries or other regions in the world, but we should not necessarily apply them to our populations, because we may have a totally different population when it comes to amyloidosis, especially when we talk about the hereditary type of cardiac amyloidosis, because the mutations that are maybe present in the mutation, the different types of mutations is regional. So what mutations they exist in North America, they're different from certain other countries in Europe, and even within Europe there are differences in the prevalence of these mutations. And also these mutations are different from mutations that are found in countries in Asia. So we may have a little, we may have different mutations in our region, and we have some information about this, and that I will show you in a second. So the study was a USA population. There were a lot of Afro-Americans, I guess, in the populations. We don't have Afro-Americans in our populations. Older age, we see younger patients in our region, I guess. And probably most of these patients, I wouldn't say most, but I think they had more wild type ATTR amyloidosis than hereditary type amyloidosis. And so the question is, does this score apply to our population? Do we need a modified scoring system? Well, let me just give you, I'm the director of the National Amyloidosis Center in Amman, Jordan. And we opened the center in about 3 years. And over the 3 years, from 2020 to 2025, we've diagnosed 28 patients with ATTR cardiac amyloidosis. And 8 of these were ATTR wild type, and 20 out of the 28 were the hereditary type. So more than 2/3 of our patients are hereditary and not wild type. This is not the proportions that you see in other countries from the West. In the West, it's either equal or there is a little bit more prevalence of wild type cardiac amyloidosis. And Suraf can correct me if I'm wrong, but you see either equal distribution or even more wild type ATTR amyloidosis than hereditary type. So this is the first difference between our population and the population in the West. And if you look at the mean age for the wild type, it's 72 years, but we had patients as young as 46 years. And for ATTVR, it's even younger. The mean age was 60, with patients as young as 45 and up to 75 years of age. So our population is younger than the population for the fact that we see more patients with ATTRV. And our population is diverse. So they're not all coming from my country, Jordan. We actually had 9 patients from Jordan. We had more coming from Iraq, especially from North Iraq. But we also saw patients coming from Libya, from Sudan, and also from Yemen. And I'm just talking about those with the ATTRV cardiac amyloidosis. I'm not talking about all the patients. So these are with the hereditary type of cardiac amyloidosis. So to start with, you can see that we're talking about a different population. Now, if we talk about the mutation, and this is extremely important, of the 20 patients with the hereditary type of cardiac amyloidosis, the majority, 15 of them had the T60 or T80 ALA, the threonine AT-alanine mutation. Some people call it T80A or T60A. It's the same mutation. We had 1 patient coming from Sudan, and this is where patients, in America, they're Afro-Americans. They come from, the interesting thing is this patient comes from Sudan, which is on East Africa, while the disease is more prevalent in West Africa. But this is the Sudanese patients with the VAL142E mutation. We had a Jordanian, the first ATTRV Jordanian ever diagnosed with hereditary ATTR, and he had the V50 adult onset. He's doing very well. And very interestingly, we had a family from Libya who had the lysine 55 asparagine mutation, which is a mutation that was only described in China and was not described outside of China. So we have a family from Libya who had the same mutation. I searched the literature to find if there are cases of L55A mutations outside of China. There were actually none. So we probably have the first report of a family from Libya that has this mutation. This was discovered in an old woman, and when we did screening, cascade screening for, she had 2 sons and a daughter. All 3 of them had the mutation, but 2 were phenotype negative, and one of her sons was phenotype positive. So he had the mutation, and he also had the disease. And we also had patients, one patient with SIR43 ASN mutation. Now, if we look at how they present, and this is, again, this is very important because the way these patients present may be different from the way other patients with other mutations present. And I'm saying this is because if we are going to design a scoring system based on symptoms and presentations of our patients, these things should be included in a proposed scoring system for this region. Weight loss, very significant weight loss was seen in 10 patients, 10 out of the 20 patients, so in 50%. Chronic debilitating diarrhea was also seen in about half the patients. Neuropathy was very common. 13 out of 20 patients had significant orthostatic, significant autonomic and peripheral neuropathy. And heart failure presentation was seen in 15 out of 20 patients. So the presentations of our patients are different from patients, from the presentation of patients with other types of mutations, and also with patients with the wild type cardiac amyloidosis. So with that, I end. I hope I've convinced you that screening is important, and that we also have to, as Saraf said, genetic screening is a must. It doesn't matter if the patient is 40 years old or if the patient is 99 years old. All of these patients should have a genetic test, because this is an opportunity for you to perform cascade screening and find the disease in their younger relatives long before the disease is advanced and hard to treat. And I think another important point that I would like to say is that if people who are listening to this, maybe a lot of them, they also come from this region, we need to put our hands together and try to collaborate with this, because the more data we have from this region, the more we can really construct a picture that is accurate and clear about the prevalence of the different types of ATTR amyloidosis in different parts of the world. So anyone who has cases or was involved in treating patients, and I think we need to maybe through Firas, since he started this initiative, is try to have a database that includes all these patients from all the different countries in the region. With that, I come to the end. Thank you so much, and I'll be very happy to take any questions.
Thank you so much, Ramzi. That was a very neat study, and your presentation was absolutely remarkable. Nice analysis and nice critiquing of the article. For the sake of time, I'm just going to take a couple of questions, one for you and one for Saurabh, if you may. The more you hear about amyloidosis, the more you think, your perspective and Saurabh's perspective, you're almost talking about different disease processes. And this is one of the fascinating aspects of the disease. My question is, do you think the database or this model that you described, Ramzi, would perform as well in a patient population like Saurabh's? And in other words, aren't these predictors heavily dependent on the training set in which they were developed? What do you guys think?
Saurabh, answer first.
No, so I agree. I think it all depends upon the phenotype, number one. Number two, if you're using an EMR-based model, you have to understand who is entering the information in the EMR. It is being manually entered. It is not automatically screened from an echo report or an EMG report to say, okay, carpal tunnel syndrome. is reported or diagnosed, somebody, a healthcare professional, a physician has to actually type into the EMR saying ICD-10 code, bilateral carpal tunnel syndrome diagnosed and so and so date. So it's not foolproof. We see many patients who complain of neuropathy that has never been reported in the EMR. So the EMRs are only good for what they have the information within themselves. They cannot search information that's not there. The other issue is even if I had, let's say, example for echo reports, we say apical sparing is seen, think of amyloid, so on and so forth. That statement is not a searchable statement either. So a lot of this falls on at the physician level, the healthcare professional level, to put the pieces together and say, okay, this is there is amyloid. We are really not doing a good job confirming or diagnosing amyloid in patients who have the classic red flags. We are not doing a good job in sending patients for testing who have these multiple easily recognizable red flags. And I think the third step, which comes after the first two, is then doing a wider search in the EMR or some other mechanism. But I think a lot of these things cannot be applied in many health systems. And that's why I had opened my talk by saying that we as individuals know our health institutions the best, how our EMRs work, what infrastructure we have. And within that, we will have to develop something. Even it may have the same clinical features, red flags, but maybe search them or dig them out differently than what other people have done. So, the AI-based patch in a particular EMR vendor may work in one institution, and it doesn't work in the institution maybe five miles south in the city. So it's not applicable widely, at least the way it is right now, because of these inherent limitations in just how the EMRs function.
Ramzi, any comments?
The Ramsey is frozen.
Yeah, I totally agree with Saraf. I think for me, and I think maybe trying to think of this instead of relying, which has a lot of problems, as Saraf said, why not we try to pinpoint and try to build a score based on that, so that when patients see patients, when physicians see patients in their offices, they're evaluating a patient with heart failure, for example. So let's take that as a beginning, because you have in our region,
Ramzi, you're cutting off. We can't hear you very well.
HRM. Sorry. Can you hear me?
Now we can.
So now you can hear me, right?
Yes.
There. Okay. Should I repeat or just continue?
Keep on going.
Yeah, so I think, I was saying that the three systems that are heavily involved with amyloidosis, with the disease, are the heart, the nervous system, and also the gastrointestinal systems. So if we, design a clinical score based on these symptoms for physicians to think about amyloidosis when they see patients who come in with a polyneuropathy or nervous system involvement, or with heart problem, or with gastrointestinal problem, to give them, to have a list that is available to these patients. They can check certain points, and then if they collect 3 or 4 or 5 of these points, then they have to refer this patient for further testing, including an echocardiogram, maybe some cardiac markers initially, and an ECG, and then see if these patients need to have more further workup. So this is, I'm thinking of it in a prospective manner than retrospective, going back to records of patients who had already been seen previously, and think about the patients who are coming to our offices starting from today and then tomorrow and the day after tomorrow, and see if we can diagnose those patients and help them out. So that would be my suggestion.
Great, valuable, sage advice from both Sorab and Ramzi. I want to be mindful of time, and I would like to thank you both for your insightful presentations and valuable comments. And I would like to alert the audience that watch out for the next session that will be coming out of Gulf Amyloidosis Club, will be coming in November. Until then, I would like to leave you with the thought: think amyloidosis, talk amyloidosis, and treat amyloidosis. And with that, I would like to conclude this session. Thank you so much.
Thank you.
Thank you.
Good night.
Thank you. Bye-bye.
Bye-bye.